Okay. Welcome all for the second webinar series of pediatric GI endoscopy. So over the period while on interacting with other people, I got to know that many people are doing endoscopy in pediatric patients, our own pediatric surgeons. And so then I thought that we can have a first-hand experience from their side. So here we have two people to share their experience. One is Dr. Amit Kumar. He's a pediatric surgeon from All India Institute of Medical Sciences, Patna. And another is Dr. Jay Kumar, who is pediatric surgeon from Salem. So first, so they'll be speaking about the different training process that a pediatric surgeon can opt to learn or to get trained in GI endoscopy in pediatric patients. And Dr. Jay Kumar himself has established the pediatric GI endoscopy equipments with him, and he's using it for prior practice. He can give us a lot of he can give us first-hand information about what was the process with which he has procured those instruments. So let me introduce you, Dr. Amit. It's my privilege to introduce him. He is Associate Professor in the Department of Pediatric Surgery in All India Institute of Medical Sciences, Patna, and is working there since the last 6 years. His special interest is in pediatric GI endoscopy, pediatric minimal invasive surgery, surgical oncology, and he has many publications in his name. And he has also won the best paper in IAPS conference in Kolkata. Over to you, Dr. Amit. Please tell us something about the training that you have undergone and what are the different ways in which a pediatric surgeon can get trained in pediatric endoscopy. Over to you.
Thank you, sir. I'll just share my screen.
Yeah, please do.
Is my presentation visible?
Yes, it is visible.
Yes, sir.
So a very good evening to all of you. And today I am going to talk about training in GI endoscopy in India. So at the very outset, I would like to make this clear that whatever information I have got is from my personal experiences and the data that I have got from the extensive search of the literature, because for pediatric surgeon there is no fixed course or design through which we can get trained. So we have to work hard and make it work somehow. So the first question which comes to our mind is who should perform the procedure? And obviously we see adult gastroenterologists, they have a vast exposure. They are getting lots of patients day in, day out. So the more you do, the more you learn. The concept is same. So they have a good experience. Pediatric gastroenterologists, they have limited exposure because not much patients are there and not much centers are there. Even if you see in your town, very limited or medium to small towns, very limited people will be doing pediatric gastroenterology and endoscopy kind of thing, and it is genuinely required at times. Indications, all of us know that. And as a pediatric surgeons, we have the advantage that once we get into the learning, we get into the training, we will realize that we know the anatomy better. At least we can imagine it in a better way. All the how the esophagus will be, how the stomach, colon, everything what we do. So we can grasp it faster, learn it faster, and like that. So these are the type of opportunities which are available. And the first line is not designed for pediatric surgeons. We all of us will agree to that, that DM courses, PDF courses, PDCC courses, all these courses are there. And pediatricians or medical colleagues can opt for these types of courses. What is available for us is fellowships, short-term fellowships programs are there, certification courses are there, and the last one is the clinical observership at good volume centers. So like and there one question also keeps coming and is highly debatable also, that when you are certifying that somebody is can do a colonoscopy or esophagoduodenoscopy, then what is the minimal criteria? So there is no consensus per se, but there are many recommendations from this one I found in Joint Association of Gastroenterology. They said that one to certify, one should have assisted cecal intubation rate more than 90%, rectal retroversion rate of 90 plus percent, polyp detection rate 15%, polyp retrieval rate 90%, patient comfort factor should be there, attaining a minimum colonoscopy count of 280 or 200. That keeps on varying, and this list is also long. These are not the only ones, there are many more points, but in our country it is not very strict. So after extensive search and experiences, I have found that these are the centers. But I will agree that these are not the only centers. There could be many more, and which must be running in and around your region. But these are the prominent ones: the World Laparoscopy Hospital, Sehgal Minimal Access Surgery Training Institute, Association of Minimal Access Surgeons of India, and the Institute of Medical and Minimal Access Surgery and Training. So I'll talk about briefly about all of them. So those who are interested can inquire more into the thing and can get training from there. So the first one is GI endoscopy hands-on training fellowship course at World Laparoscopy Center. So they usually this endoscopy fellowship training starts on 7th to 12th of every month, and this is an evening course actually from 4 to 8 p.m. like that. They are running it 6 days fellowship in upper and lower GI endoscopy they are providing, and the best thing is that they target the beginners and the intermediate level of learners. So it is good opportunity, and they are charging a few fee of around 70,000 for that. Look, it is located in Gurgaon, NCR, Delhi. And the good thing is they are providing you accommodation also at the hospital premises itself, as well as they have a owned hotel also from where you can get the accommodation, and you can contact on these numbers for the needful. The second one in the list is a Sehgal Institute, where they are also doing it on a monthly basis. They are starting on 23rd working day of every calendar month. 4 days course. They are admitting 5 patients, five students or those who are interested, and they charge 50,000 rupees. It is situated in Delhi only, and those who want a quick start can join this, which is very near by Amasi on May 16th to 18th 2025 itself. So this is also a very good opportunity if anybody wants to do it on a quick basis. That's why I have included this also. And so these are the few. There can be many certificates and fellowship kind of programs, but apart from that, there are clinical observerships. These clinical observership you can do it at your institute. If your institute has an adult endoscopy facility, you can make friends with them and go and do a observership, or at some very renowned institutes also they are doing. You can join the clinical observership and do the experience. I will talk about two institutes where I have had my personal experience. It was a very good experience to have clinical observership at these places. The first one was SGPGI Lucknow, and You can do a clinical observership there. So the site is there. You can mail to the dean at the rate sgpjac.in. And once you get a NOC, you can go there and do observership. And they are doing, I did there for 2 weeks. And actually, they are doing 2 days exclusive pediatric GI endoscopy. Exclusive pediatric GI endoscopy. All kinds of diagnosis you will get to see. I'll say almost 70 to 80 minutes in a day. And apart from that, they are doing therapeutic also. In fact, in India, there are only two places, institute kind of places. One is SGPGI, another is PGI Chandigarh, where you will get pediatric patients, a lot of them. So this is a recommended one. And last year I went to AIG Hospital, Hyderabad, that is Asian Institute of Gastroenterology. They also have a vast setup and huge input of patients. Uh, like there are 10 rooms in a row, and non-stop endoscopies are being done from morning till evening, and both diagnostic as well as therapeutic, all kinds of things are there. A very good exposure, how to handle, how to see the anatomy, and all those common diagnosis. You can just a couple of week and you will understand the anatomy well, that I can assure. But the biggest drawback or the negative part at this place was that pediatric patients were very less. Most of them were adult patients. Okay, this was my last slide, and the list is long. I'm sure that there would be must be many more which you can add. Sir will add at the end, and the next Dr. Jay will come. He will tell his how he has procured his personal this thing. And I'm working in an institute, so I just want to highlight that getting the GI endoscope in institute is very tough task and a time taking task. Actually, if you start from today, I don't know, 2 to 3 years you will take, then all the tender process, bidding, everything will be there, but it will take time. So if you are thinking of it, if you are working in an institute where this can come, so don't wait that you will get trained and then you will start getting apply for this. So better start now so that you get it in time. But the best part is institutes, if you get the good GI endoscopes, like we at AIMS Patna are having 190 series Olympus. It is a very nice endoscope. So that's all from my side.
Yeah, thank you, Dr. Amit. You have given a good overview of how can we go on with the training for the pediatric gastroscopy and colonoscopy. And if there's any question from the audience, you may post it now, or you may ask directly, or we can take the question at the end. Okay, now, if there's no questions as of now, I would like to invite Dr. Jayakumar to the next talk. The main purpose of his presentation is he has been working, yeah. So he has been using endoscopy since last 7 to 8 years, and he has procured his own endoscope. So then definitely he would be well versed with the different types of endoscope available, the cost, the maintenance of it, and everything. And that's how he would have chosen a scope that for himself. So it will be his first-hand experience, and I would like to call Dr. Jayakumar for the talk. And before that, let me give his brief introduction. He is currently working as assistant professor in Department of Pediatric Surgery in Mohan Kumar Mangala Medical College, Salem, and he has many publication in his name. And he has also worked for the upliftment of HIV and AIDS, and he has also received fellowship, Fogarty Fellowship for the same regard. And over to you, Dr. Jayakumar. You can share your screen.
Yes. My screen is visible.
Uh, yes, your screen is visible. Yes, your presentation is.
My slides are visible now.
Yes, yes, it's visible.
Okay. Thank you, Akshay and IAPS for giving me this opportunity. Just you asked me to talk on logistic uh, on installing the endoscopy unit. I am trying to make it interesting. I will try to bring the videos and the other things. How I can make this presentation interesting. In the main logistic, which includes the endoscopy suite, includes the processor and scopes. Uh, the processor and scope should be in the same brand. We can change we can use a different scope in different process. On the screen, we can change it. Recording system can be a desktop or a laptop, and the recording software it's depends on the provider and it's our wish. And the accessories, uh, which is important to work with. We are going to work with the accessories only, and where we are going to set the unit. And after use, we have to sterilize more than. Uh, can you hear me? It is showing that my internet is unstable.
Your voice is audible. Can
Is
please
it
go.
stable?
Yes, yes.
Okay. Uh, okay. Uh, the more than a sterilization, it is a disinfection process, not a typical sterilization like laparoscopic instruments. Then storage and transport of the instruments and other accessories. This is my endoscopy suit in my OPD. Uh, from the left side, what we are seeing is that the examination couch can be converted into the endoscopy couch by just shifting the pillow to the right side. And uh, and we can see the monitor. This is a medical grade monitor, and this is the lignocaine spray which is used for adults. For in case of pediatric, I usually do by general anesthesia most of the endoscopies. I don't want to do it for in local anesthesia in the with the spray only. Only one patient I did was my friend's son. He was a 10-year-old from US. He is willing to do it without anesthesia, so I did it. Then this is the mouth guard. This is the processor. I am using Pentax. This is the scope. This is the air water channel. This is the printer. Uh, at the end, we have to print the reports. Uh, right side, this is the laptop I am using because I am a freelance surgeon. I can go with the desktop. Um, Below, we can see the tub with the RO water to check my scope and everything. This is the basic setup. And I will show you the another setup in the right side. This is the setup in the other hospital. No, the instruments are mine. I have to set the system there to do the scopy. With the simple small OT table, I arranged everything. The only change was the monitor. I usually carry the HD monitor of Dell. This is not a medical grade monitor, but the vision will be good with the both the monitors. This is another hospital with the endoscopic trolley unit. We can see here the screen is a TV, Sony TV. I don't think that this is inferior. Actually, this TV also sometimes I feel it is better than our medical grade monitors. I don't know. This vision is better. This is our Indian make endoscopy system, automates Mitra endoscopy. Uh, what are the endoscopy sets available in market are mainly people are buying Olympus, Pentax, or Fujinon, and Indian makes are the Automates, Mitra. These are all the currently people mostly used items. Some China makes and some other Indian makes are also available, but I am not well versed with those things, so I didn't talk about it. Uh, what is the price of this sets? Uh, most of them. This set includes endoscopy and colonoscopy both. The new one is uh, 27, 28 lakhs. All includes the what they are quoted, but the final price will be negotiable around 24, 25. Everyone is telling. Uh, Coming to the our Indian make, it is 18 lakhs, but we can go with the basic model for 14.5 for both endoscopy and colonoscopy. If we want to go with only endoscopy, it is around 15 for all the three Japanese items, and for our Indian make, it is around less than 10, around 9 or 10. The problem with Mitra is only problem when I encourage them. If we want to upgrade, now they are selling two varieties. One we can go with endoscopy and colonoscopy. One we can go with endoscopy and ERCP. We can combine all the three scope in a single processor. So it is better. My suggestion is always go with the uh, Japanese models. They usually adopt all the scopes in a single processor. Now what I am having is Pentax. Now my endoscopy, colonoscopy, and ERCP processors. My processor is basic version, but my scopes are high-end version. I can upgrade my processor later. I already upgraded my processor from the basic version with the halogen light to xenon light last year. Next, I have to go with the HD and other image banding. Then I can upgrade it. It is not possible with our Indian makes. Now coming to the data management, uh, with a laptop, you can see a software, Capture IT Pro, which is from Soft, a company called. Uh, Wherever I go, most of the places they are providing this software only. I have seen with Olympus, Pentax, and Mitra also they are using the same software. This is the software. This is the we can by using this software we can capture the images and record the videos. After recording the video, we can capture images later also. Coming to the accessories, which is important. For basic endoscopy also need some accessories, including the biopsy forceps. See this forceps, this is 1.8 millimeter diameter forceps, which is a pediatric forceps. What the scope I am owning is a adult scopy, but we can use this forceps also. But this forceps is for 5 mm scopes. 5 mm scopes are available with Olympus and Pentax, both to my knowledge. I have used Olympus. Pentax, we are having the 5 mm scope, which we didn't use, which was damaged. This is the normal adult biopsy forceps, 2.8 millimeter outer diameter sheath, and the length is 230 centimeters. So I can use it for both endoscopy and colonoscopy. Endoscopy length is around 105 centimeters. Colonoscopy is around 170 centimeters. So I can use these forceps in both endoscopy and colonoscopies. The price is 9,500 they quoted, but actually the price is 2,000, around 2,000. This is Indian make. You can see the spelling of accessories and forceps, but not the quality of the forceps is not good, really good. Don't think it is inferior compared to the other brands. This is the forceps with the spike. The needle spike will help to taking the biopsy without any interruption. It will not slip while taking the biopsy. This is the rat forceps to know to show how the forceps and the rat tooth work. All the instruments accessories work mostly this way only. This is a Rothnet or net forceps, which is used to hold some coin or batteries without damaging. We are taking out, it will not damage the mucosa. Very good instrument. This is CBD basket, common bile duct basket, which is used for the ERCP, can be used in our practice also. The same basket, the Dormia basket, which is this is the watermelon shaped rubber in the stomach. I tried with the rat tooth, it failed. So I used the metal basket to hold the rubber. Always don't pull the forceps. Like our cystoscopy, it should be taken out together as a complete set. Another accessory is a polypectomy snare. It can be used in different ways. This is a child with a small button battery with full stomach of banana. I used all instrument. I can't catch it, but at the end, with the snare, I can hold it very easily and take it out. This is a colonoscopy. This is an upper rectal polyp in a child. I can't reach with my finger, so I use this colonoscopy and put the snare. I didn't snare it. I bring the polyp down and I ligate it. This is a cexoscopy. This is an injection needle which can be used for an injection of the adrenaline in case of bleeding, or for glue injection in case of the gastric varices. The one item I always afraid to use is this glue. If it is going to spill over our lens, it is going to damage our scope. The repair will be very costly. Another accessory is a bipolar probe and monopolar probe is available, like our monopolar and bipolar instruments. Here also probes are available to deal the bleeding. This is the bipolar. This is the monopolar. This monopolar came with a needle. We can inject with the needle also. We can inject and cartridge. Both we can do with this needle in case of any bleeding. This is the grasping forceps or rat tooth. This can be used to hold this is 5 mm 5 mm Olympus endoscopy. This is a 1.8 millimeter rat tooth, which is holding the open safety pin, and we can remove it safely. This is a wheel of a band applicator. This is a band which can be used for the ligation of the varices, esophageal varices. This this band cap is very useful for us to protect our scope. The first video is how we are applying the bands. We can see the black color circles outside. After application of the bands, one by one, 6 bands will be there. After application, the scope will be clear. There will be no black rings. So this cap can be used to protect our scope. We can see it later. This is a fixation device, nothing but a clip. This is through the scope clip. Like the band, we can have over the scope clip also, which is very costly. It costs around 40,000. This is cheaper. This is every clip cost around 1,000 rupees. This is the same another clip applicator. This is the hemoclip clip applicator. What I'm holding is the clip. We have to insert inside and lock it. The scope will be fixed. Clip will be fixed. This is a clip application in a dolophi lesion in your stomach. Next is a balloon dilator. This is 8 to 10 millimeter size dilator. This is the balloon inflation device. This is the device. This is a screwing type of device. Another is a gun like alligator gun, which also used to inflate the balloons. This is the balloon dilatation of your stricture. This is after dilatation, inflation, deflation. This is a 12-year-old female child with a TEF operated, multiple dilatation done. At 12 years, she came for some swallowing difficulty. When we did checkscopy, this is a 2 centimeter balloon. 2 centimeter balloon freely we can pass over the TF anastomotic area. So there was no stricture. This is the guide wire. This is the endoscopy guide wire. This is actually a stiff wire. See, this is stiff wire, but the tip is very flexible and soft. The tip is very flexible and soft. The guide wire is passed into the stricture area. Then we have to use the dilator. This is the Savory dilator set, which is used to dilate. This is the dilator set, which came with 5 millimeter to 1.5 centimeters. This is the dilatation over the guide wire with the C-arm guidance. Next is cytology brush, which is useful to take cytology of some, in case of any fungal infection or in case of we suspect any tumor, we have to brush it and take the biopsy. This is the cytology. We can see the brushing the ampulla and taking the biopsy. This is percutaneous endoscopic gastrostomy kit, which price is they quoted as 7,400, but actually this is around 5,000 only, which can be done by us easily. It's not a big deal for surgeons. Okay, all procedures are over. Now we have to clean our scope by using the cleaning brush. This is the cleaning brush I am holding. The next right side video is how the brush is passed into the working channel, and the brush should come out of the tip and it is inside the RO water. So we can see how it is cleaning the channel. After brushing, now I have to push RO water into the channel to clean the remaining dirts. After cleaning the scope over and inner, now I have immersed in the side X. If we have to do another scopy, we have to immerse minimum for 20 to 30 minutes. This is how we are disinfecting. We are not sterilizing. Endoscopes, we are disinfecting. After disinfection, we have to clean the scope. The first one is the colonoscope. What I'm doing is I have to drain the water from the scope. In the air water channel, there is a lock. I have to lock it. After locking, I have to press the inferior button. Inferior for insufflation and irrigation. The water from the scope will come out. At the end, only air will come out. The air will dry the scope. The same done for the gastroscopy. This is how after removing the water, now I have removed the upper superior button, which is for superior for suction. By holding the superior button, I am sucking all the remaining water particles from the scope. This is same for the upper GI scope. Afterwards, I am using a blower to clean the remaining water inside the scope. This blower is nothing but this is a car vacuum cleaner. Can be used as a blower. This is available in Amazon for 500 rupees. What I use for both endoscopy and laparoscopy instrument drying. We have to clean the knobs also. We have to dry the knobs, and sometimes we have to apply silicone oil for the knobs for easy mobility, to avoid friction. So everything is over. Now I have to protect my scope. You see, the first picture is the scope without any cap. The second picture is with the cap. The cap is nothing but which we used for the banding. That is, anyway, the cap is no use. But I used to use this cap to protect my scope. I always put this after cleaning. I will put this cap, which will protect my scope. If if the scope is going to slip from our hand, it is going to hit the floor. Uh, do you know how it is going to cost? If it is going to get damaged, as per the company person, the scope is no longer usable. You better don't go for service. Better replace this. This is advice. Always protect the. After cleaning, after protecting my scope, I just use company supplied box for storing. And what I do extra is I put formalin inside for extra precaution. I use this as a formalin chamber. I have a separate box for gastro and colon, and separate suitcase for ERCP also. This is the carry case. If my boxes are damaged, this can be bought from the market, which is available 4,000 to 5,000 rupees. If you are going to have a stable unit in a hospital, you can have an endoscopic cupboard. You can hang all the scopes inside, but the cupboard should have light, which avoid the fungal infection and other things. This is a scope in a hospital which was damaged. This is a Mitra scope which was damaged because of the hospital didn't touch the scope for 2 years. When I went there, they told me, sir, you can do endoscopy, we are having scope. First patient, I put the scopy. When I am reviewing the scopy, most of the teeth inside went inside the patient. So this can happen. Always use the instrument monthly once or twice. Whether we are using it or not, we should take it, clean it, and kept it back. Check it and keep it back. The same scope repaired. Do you know the cost? Simply for the seat, it costs 60,000 plus, 60,000 plus as per the owner. If it is going to be a branded on other brands, it is more than a lakh for the seat itself. This is a scope, which is my senior assistant told me that we are having endoscope, but only we can see. We can't do any procedure with that scope. I told I want to see it. When I saw that scope, this is a 5 mm pentax scope. Vision is good. It is having a working channel also. The thing is, the person who used the scope didn't allow touch the scope. The scope is unused for years together, and this sheath also damaged. Now we have to replace the sheath, but actually it's a good scope. This is a we have to see through eyepiece, but with the coupler or a joint, we can use with our laparoscopic camera, so everybody can see. Thank you.
Thank you, Dr. Jayakumar, for the wonderful talk that you've given. It's a first-hand experience that you're sharing, so that's so nice about it. So I can see that there is one question from Dr. Arvind Radhakrishnan, that is brush cytology only for periampular lesion?
No, it can be done for anything. I told for fungal infection also we can do it, brush and send for smear. Brush cytology is to take the sample. That's all. Yes, Krishna asked the Sidex. Yes, Sidex can be used to clean the scopes. I used to put in the Sidex in my clinic. When I am going for the private in the freelance, where I can't get the side X, what I do is I used to put Sprit or Sterilium over the scope with the help of pad and swipe it and I wash it, but which is not recommended. The reason is it will reduce the um, quality of the scope. The sheath will get damaged easily. We 8 mm scope. We can use what 8 mm? You can use all adult endoscopy in more than 10 kg. More, I have used for 8 kg also adult scopy, but we should use it regularly. Don't push it. It should be gentle. Otherwise, we will perforate anything.
Okay, if there's no more question, then I will just sum up and add a little more to the previous speaker what they have spoken. So basically, this is a session for us to make all the pediatric surgeon understand that endoscopy should be part of our curriculum in the teaching program. And if that is so, then everybody will be able to use endoscopy in their preclinical practice. And people who are interested now and who have not been trained can get themselves trained and they can use it in their clinical practice. So in this regard, uh, is my slide visible?
Yes, sir, visible.
Yeah. So in this regard, I'm just going to add Dr. Amit and Dr. Vijay Kumar have made my job very easy. So there are certain slides which are actually we might see that it's duplicated. I'm going to skip those. And so the topic is logistics in pediatric endoscopy as to how can we sustain the cost of the endoscopy when we start doing it, because we have certain challenges like number of cases that we have is less and the cost of the equipment is more. How can we overcome that situation? So let's talk about that. So some of the slides you might feel that there's a projection of the brand names, but this is only for academic person. It doesn't have any intention of advertisement. So the agenda of the talk is endoscope and gadgets has already been discussed extensively. I'm not going to get into that in my talk. I'll be very brief about it. Expense and dealers have also been uh, explained. Setup also has been explained, so it's going to make my job very easy. Now I'm going to concentrate on the challenges for pediatric surgeons and how to overcome these problems, especially in managing the finance. So here, whatever scope you take, basically they look the same. There are certain certain small specification it would change. So based on that, we have to plan our purchase of the scope. Otherwise, all these components like control section, insertion section, connector section has already been dealt with by the previous talk is almost the same. Now here, I would like to highlight that what are the difference between gastroscope and colonoscope. So gastroscopes are usually shorter. So they are meant for upper GI endoscopy. So they are slightly smaller in diameter, and they have the field of view is around 140 degrees, which is quite enough for us to inspect the bowel from inside. And one thing which is important over here is the bending capacity is less for gastroscope compared to the colonoscopy. If you see the colonoscopy, the bending capacity is more. It's little wider and then it is longer. And now, because of the recent advances, especially Fujinon, they come with the scope which you can change the rigidity of the scope. Because in certain places we need to bend to access into the curvature of the intestine, and in certain places it has to be sturdy to avoid loop formation while entering the long tube. So they have option of making it flexible and rigid. Otherwise, the specifications looks like this. I'm not going to go into much detail. This is like when we take a catalog for any of our surgical instruments is the same. Only one thing I would like to add over here is most of the gastroscope comes with 140-degree wide angle, and the range of bending angle is lesser for gastroscope compared to colonoscope. Colonoscope have wide bending angles. Okay, this has already been dealt with. Here again, I have put the same companies. So all are Japanese companies, and the last one is Indian company. And I don't have very personal experience with Pentax or Mitra. Here we use Olympus and Fujifilm. I just want to highlight over here that each scope, once you start handling the scope, it has got its own advantages, disadvantages, the comfort with which you can use the scope. And the Olympus are very light scopes compared to the weight of the scope is less, and they are very smooth to handle. And sometimes it is very handy for us to use it for children. Like there was a question there at in the previous talk that whether we can use 8 mm scope. Yes, Olympus, even bigger scope also can go slide in very easily. It can be maneuvered very easily. And Fujifilm is, they have a very smooth surface, but they are slightly rigid scopes. So if I have to dilate esophagus or dilate the duodenum, which has small stricture or small stenosis, I would prefer a Fujifilm scope rather than Olympus scope. Or if I want to use it for some biopsy purpose on some particular site, then I would prefer a Olympus scope. Pentax and Mitra, I don't have personal experience. I'm not going to speak about it. Now here I'd like to add that there are certain other costs also which comes up when we are doing endoscopy. The one thing is the personnel. Like either Dr. Jayakumar has shown how he himself is taking care of scope. That is really good because it takes a lot of pain and effort to take care of the scopes. Otherwise, you can see that the scopes get spoiled. The end of the scope, there are CCD devices which can get spoiled if not handled well. So we need to have personnel who can take care of it. So in that case, the longevity of the scope or instruments are increased. Other than that, there are these are the light sources. Nowadays, what has happened is it is happening in other instrument section also, where there are the life of the endoscope lights are limited, like say 480 hours to 500 hours. Soon after you complete your say 500 hours of the use, it gets switched off. Then you have to replace the light. And this replacement of the light will cost you quite a bit, something like 50 to 60,000 rupees. And then these scopes actually initial first few years it doesn't give any trouble, but later on you might have trouble with certain leakages from the working channels or from the water channels or air channels. In that case, you will have to take the help of the service providers. So what is usually practiced in institution is they have a annual maintenance cost and annual maintenance service. So it is possible once you have a more number of scopes, many instruments to handle. So it is worthwhile taking AMC services. But otherwise, if you are having 1 or 2 scopes, it becomes very costly affair. So third thing is if you recording systems are not always associated with the scope, you have to make your own arrangement of recording, which has all beautifully shown by the previous speaker. And again, if you want to make a good reports out of it, you have software for that. For that also, you have to based on what is the requirement, you might have to pay for apps. So these are the other costs that incurs when we are planning for a endoscopy or planning to build an endoscopy unit. Word about refurbished scope. Refurbished scope is actually these are the scopes which have been serviced. Otherwise, it was a spoiled scope, or they are sent as a say seconds in a seconds market. Refurbished scopes, we have to take it with a pinch of salt because we do not know what kind of damage has happened to that scope and how it has been corrected. So always it is better to buy these scopes with the experts. Like there are technicians who handle scopes very regularly. They'll be very much, very well worth knowing about the scopes. You can take their help. Otherwise, it's not very much recommended, although you get these scopes for around 30% of the total cost of the new scope, because most commonly these scopes will have either issues with the camera, issues with the lighting system, or more often they'll have some leakages from the water channels or the uh, air channels. Nonetheless, if your budget is very less, you can use this. Since we are not using scopes very oftenly, and most of the times, if you are single-handed using the scope, even refurbished scope are also not a bad option. But provided that when you buy it, you have to be very careful. And another thing is, once it gets spoiled, you don't have a regular service available for that. So that has to be kept in mind. Now, based on different gadgets, is already spoken about very well. So I'm just going to skip this. So this is another, this is a Titan balloon, which actually CBD balloon, dilating balloon, which is used by gastroenterologists. And most of the times when we come across small children, we might not be able to use CRE balloon for dilatation of the esophagus. Rather, we might have to stick on to this particular, is a very good gadget for us to dilate, especially when you come across an infant with esophageal stenosis after tracheoesophageal fistula repair. So this could be one good gadget. This is one just wanted to emphasize on. So this has already been talked about. I'm not going to talk about this. And this is setting up of a unit of endoscopy. Here it is like setting up of a daycare center or daycare surgical center. So as all of us are surgeon here, I'm not going to give much importance to that. Everybody knows that we should have all the amenities which is there, even including biomedical waste management system. Here, what is recommended by the Indian set guidelines or even in the Western guidelines also, that you should have a room size of 36 meters square. And if you are using other gadgets like CRM, you may have to use 42 meters square of the surface area of the room with the 3000 millimeter, that is 300 centimeter of the ceiling specification for the room that we are performing. And you may have to use lead sheets if you are using CRM. So this I want to emphasize here that the room in which you are doing, especially by doing it in OT setup, we should have a bigger OT setup so that you can accommodate many people over here: anesthesiologist, endoscopic technician, yourself, nursing staff, CM technicians, and you should have a bigger room. That's what I just want to emphasize here. Now, the place of training has already been explained well by Dr. Amit. Not going to touch upon this. Here, there's one interesting article from Pediatric Gastroenterology and Hepatology and Nutrition Journal from the Asian point of view, where around, I think, if I'm not mistaken, 27 centers have joined for this study, where they said that most of the center, they don't perform more than 10 endoscopy per week in pediatrics. This is just for pediatrics. So, and then in that case, how are you going to train your younger people? So in that, they have suggested that, so what they have identified is in the Western countries, the number of endoscopies are much greater compared to the Asian population. So maybe whether they are overusing their infrastructure, or the indication for them to perform endoscopies is more, the indication is more, they're not sure about it, but the number of endoscopy is more in the Western pediatric population. So what they suggested is simulation, adult endoscopy training, and followed by pediatric endoscopic hands-on should be the way to go. And most of them, they suggested that after undergoing simulation adult endoscopy, it's not difficult for a pediatric endoscopist to catch up the different procedures within 5 to 10 endoscopies, provided you had adequate endoscopy training in adults and in simulators. So this is one interesting fact that I've taken it from NMC guidelines, and this is from Association of Pediatric Gastroenterology group, where they suggested that for DM candidates, it's more number of independent endoscopies are expected out of them at the end of the course. But in fellowship program, they suggested that a candidate should have done at least 30 endoscopy, upper GI endoscopy, around 10 proctosigmoidoscopy and colonoscopy to make himself competent for performing endoscopy in future. And in that training program, there was a compulsory rotation program for in pediatric surgery unit. So I would suggest that there should be certain similar rotation shift program for even pediatric surgery residents during their residency, so that they are also exposed to different procedures, different training learning programs in even in the pediatric gastroenterology departments. Now, what are the hindrances to start endoscopy unit or endoscopy in pediatric patient by pediatric surgeons? For pediatric surgeons, it's basically the establishment of endoscopy unit itself is a very big task, which has already been discussed. Cost of equipment has already been discussed, but over that we have less number of patients. Now, how are we going to manage this? So let's try to sort that out now. So lack of training, this also has been addressed by Dr. Amit in today's session. So another thing that is one thing is challenging is for every endoscopy that you do, you may have to shift the endoscope from the endoscope suite to the operating room. So that could be a challenge. You might have to convince the administrator for getting permission for this. And you need to have a fixed schedule in your working hours so that you don't clash with other departments for doing endoscopy. Now, how do you overcome the problems? Now, there are certain factors which favors pediatric surgeons in endoscopy. One is, it has already been mentioned in by previous speaker, that many of the conditions, symptomatology wise, they come to pediatric surgeon. So hence, you might get a direct reference for any gastrointestinal problem. So that's why you might get a reference, and you can, if necessary, you may do endoscopy in these patients. So we are well versed with different diseases, anatomy, so it becomes easy for us to handle endoscopy in these children. Medical gastroenterists are not very comfortable performing endoscopies. I'll talk about it in next slide. So that's why if there is medical gastroenterologist and pediatric surgeon, definitely pediatric surgeon will have an upper hand in managing these cases. And we have usually good interaction with anesthesiologist and OT, so that to post a pediatric patient in OT for endoscopy, it's easier for pediatric surgeon than endoscopists, because they are not well versed with the OT timings and OT work patterns. Okay, so now whom all should we interact with if you want to start an endoscopy, so that we can have a financial we don't have a financial crunch, and we can get going with our endoscopy. So these are the people: pediatrician, adult gastroenterologist, pediatric gastroenterologist, GI surgeons, and general surgeons. You might wonder why pulmonologists. I'll come to this point in my future slide. Pediatric surgeons, our own people, general practitioner, hospital administrator, endoscopic technician, and endoscopic dealers. Let's go one by one. Basically, pediatricians, once they are convinced that as a pediatric surgeon, you would be doing endoscopy, so then they start referring you. And in smaller city, when there are no contenders for endoscopy, they would probably refer you if you are good in handling the endoscopy, and you keep a good rapport with pediatrician, involve them in your loop of working up the cases. And if patient comes with, say, upper GI bleeding, involve them in resuscitation of the patient, involve them in esophageal dilatation for nutritional purpose. So with this, you can have a good collaboration with pediatrician, and then you can get the references towards you. Now, I was talking about this particular thing. Medical gastroenterists are not very keen in performing endoscopy in children, because the kind of diseases that they deal in adult, they're totally different than pediatric. That we can deal with pediatric patients. Initially, in first few years of my career, whenever I used to do diagnostic endoscopies and had some difficulty, I used to ask my medical gastroenterology colleagues. They were not very confident in helping me out for my queries. Then I realized that the kind of diseases that they treat are different, so they might not be very keen in performing endoscopy in children. And the most of the endoscopy are done by the pediatric medical gastroenterologist, adult gastroenterologist are in their endoscopy suite, which is not well equipped for pediatric scopy. So they have to take the child to the OTs, which they are not very comfortable, because they have to take extra time out of their busy schedule to go to the OT. And most of them are very busy in performing adult endoscopies. Next comes pediatric gastroenterologist. You should understand here that for pediatric gastroenterologist, endoscopy in children is important job for them. So of course they'll be doing pediatric endoscopies. So they will, first of all, they have a few numbers. Say they won't like you to take up their part of work, that is endoscopy. But having said that, they will help us very much in getting the gastrointestinal cases to us. That you have to understand. And they also need large number to sustain the practice. So in that case, if a gastroenterologist is new in your city, you may definitely approach him, and you may collaborate the work, because all the caseload cannot be handled by one single pediatric gastroenterologist. So if he has to take leave, he has to anyway take the help of somebody else who can take care of his patient. So in that way, we can have a good collaboration with pediatric gastroenterologists to work with, and it can be a complementary work with each other, and we can go and especially you can help them out, especially in certain interventional cases, which might be very little difficult for them. Like you can be little bold in dilating the esophageal strictures. You can also be a part of management of bleeding, uh, bleeding varices or upper J bleeding. So you had to work in complementary with each other. Now, what is the role of pulmonologist? Here you should understand that pulmonologist definitely will have a setup of bronchoscopy, and the processor and the camera are the same for pulmonologist bronchoscopy and your endoscopy. So in that way, you can always collaborate because everybody wants to reduce their cost of their establishment. So if you have any pulmonologist friend, you can always share the same video unit with them. And again, they will have a good facility for pulmonary resuscitation because they'll be treating with the condition we have who have respiratory issues. So their procedure will be well equipped with the resuscitation kits. So that way it will be helpful for us to collaborate with them. Now, hospital administration are not interested that who is using the machine or who is using the endoscopy. So there, if you are showing interest or you are having showing the confidence, and if you have sufficient number of patients, so they'll be very happy to provide you the machine or equipments for your use. And here, what you have to understand is you have to channelize the references from the casualty or emergency room or department of pediatrics or hospital help desk towards you. So for that, you can take the help of hospital administration, and you need to fix a particular day for your endoscopy for logistic purpose. For that also, you can take the help of hospital administration for working in institution. And you may, if there is no endoscopy unit, you may ask for endoscopy unit. And if already there is an endoscopy unit, you can also always ask the hospital administration for you to make for them to make you a part of the endoscopy unit so that we can cater pediatric patients. Now, anesthesiologist's role is important for pediatric endoscopy because most of the patients require some of the other kind of sedation or general anesthesia, and so that's why. And one good thing is we have a close association with the anesthesiologist, so due to which we can communicate the things better. And certain places we can even after working with anesthesiologists, even anesthesiologists will get to know that what kind of procedure you are going to do on the child, and based on that, they can opt the kind of anesthesia that they can give it to the child once you are doing the procedure. Now, many general surgeons have their own daycare OT center, daycare operative centers. They have their own endoscopic facility, and since we are also coming under the same fraternity, we can always collaborate with them for uh, doing the endoscopy work, and we can always convince them that we can do a pediatric endoscopy, and we can also get the patient to them so that they can also have patient in their endoscopic suite. Now, one thing that we need to understand is we have to help our own people. So even if we are not doing endoscopy, if one person is doing endoscopy, it's always good for our own, is a suggestion for our own pediatric surgeon fraternity that we should encourage that person in doing endoscopy, and we can also learn from the same person because we are all colleagues. As we are creating awareness for pediatric surgery among general practitioners, we should also add endoscopy in awareness campaign. If you are doing, even if you are not doing the endoscopy, at least convey that pediatric surgeons can do endoscopy and handle JScopy more efficiently. Endoscopy technicians are important workforce in the procedure because they see much more endoscopies than what we perform, because they will be associated with many endoscopists. So they will be helping us in navigating through, helping us with giving newer ideas, and we should take their help. And service providers, it has already been touched upon by Dr. Amit, that if you are planning to buy a scope, service providers or the dealers, company personnel, they will be happy to host you or to send you for the training. So that way it will be helpful. So I hope you will be, it was a sufficient motivation enough for you all to take up endoscopy in a big way. And if there are any other doubts, I think uh, we are happy to address that.
Thank you,
Anybody
sir.
want to?
Good evening, sir. Krishna Rao here.
Yeah, hello, Dr. Krishna.
Sir, nice presentation, sir. You and others, Sir Jai Kumar, sir.
Yeah,
Sir.
thank you.
Sir, what is my question is like if for beginners like me who have not yet done even adult endoscopy also, what cases we should start as an endoscopy, sir, pediatric? What
So,
initial cases we have to start?
basically, you may start with a small, simpler cases. Like for example, you may get patients with upper GI abdominal pain. So most often it will be gastritis. And now present recommendation for gastritis is, if you are strongly suspecting Helicobacter pylori, you have to go for endoscopy and prove that it is by rapid urease test or by biopsy that it's a Helicobacter pylori. So you may do and start doing endoscopy in such patients. And then once you are, so this is a very simple procedure. So once you do the endoscopy in such patients, you'll get to handle the scope, provided you already had handled the scope. Now we are doing it in an independent manner. So by doing basic endoscopy this way, you will be able to gain more confidence and will be able to perform further endoscopies.
Okay, sir. Thank you, sir.
I want to say, I want to add one thing. We keep on seeing the ad of Dr. Sahar Javale's Scopy. But we can't do endoscopy with that scope. First one. Why I am telling is, I had that scope. I purchased the scope. Whatever would be the thing Dr. Sagar Javale is promoting, I purchase everything. I trial it everything. Okay. I'm having his laparoscopy camera to the foreign body removal forceps to this flexible endoscopy also. This is very delicate scope which cannot be used as a endoscope. I have used bronchoscopy as an endoscopy once, just for a trial in our OTE. We tried, but it should not be used. It will damage. That's why I purchased from him is I want to do a TEF case, the recurrent fistula case. I want to cauterize by using it as a bronchoscopy. For that reason only I bought it, but I can't get a working channel, working Burpee channel for that length, 70 centimeter length that scope is. But I can't get a Burpee for that instrument.
Yeah, another thing I would like to add is if you get a patient with the rectal polyp, this is the answer to the previous question. So it's not very difficult to enter into the rectum, higher part of the rectum or sigmoid colon to take the polyp. So this we can always use it as a part of our treatment. So these are the few things we can, because doing a complete colonoscopy is a difficult job. It will require some kind of experience. But zygmodoscopy, going even up to descending colon, it should not be difficult for pediatric surgeons to perform that. So I think.
Hello,
And
sir.
one more thing. And
One
one
more
more
question,
thing.
sir. Sir Jai Kumar, sir, 1 second. Sir. One more
Okay.
question. Sir, rectal polypectomy we can do with snaring and how to cauterize the base, sir? That will be bleeding, no?
No,
With just with the rectoscope, which means colonoscope.
no, I think Dr. Jayakumar has shown it. We can use cautery also there.
Okay, okay.
I think he has shown it in his.
Yeah, I have shown it. How I shown it, put a snare and bring it down, then we suture ligate it. But we can
Okay,
put cautery also. By endocut mode, you have to use in the cautery. We can
okay.
cut it. It will not bleed.
Oh, okay, sir. Okay, okay.
But better one is cold snaring and hot snaring. Two techniques are available. But the
Oh,
hot snaring is always a problem. Well, that will not bleed when you cut, but it will bleed later. But
oh,
cold snaring, it is better. Yeah, it will stop by itself.
okay, okay, sir. Okay. Thank you, sir.
Okay, I think we have crossed the time. So we'll have to end the session over here. In the next session, that is going to be on 9th April, we are going to talk about troubleshooting in pediatric endoscopy, the different problems that we might face during the endoscopy. So I'm going to get people who have been performing endoscopy and it will be more of a panel discussion. And I request the people to participate and be active in asking the doubts and clearing the doubts. I think we should be stopping over here. So I'm stopping the recording.